Alrighty, you're welcome aboard. Many thanks for joining the frequency, the family. 99.7 FM. It's a program, it's a promise. We call it Ultimate Health on Joy 99.7 FM. Listen every Sunday with me, Nortey by nature. Still in the Ghana month. And you know, a female lion is a lioness, right? Female tiger is a tigress. So what about a crab? Since it's Ghana month, we'll call it in Crabia. Stick and stay.
Joy 99.7 FM.
One from Samuel Owusu. Takes us back, way back, right? Ultimate Health on Joy 99.7 FM with me, Nortey by nature. Today we try to unmask epilepsy or seizure disorder. With me in the studio, Professor Albert Akpalu, a well-known friend of the program and of the station.
You know he's another OPK class.
He's head of neurology at the Department of Medicine and Therapeutics of the Kolebu Teaching Hospital and the University of Ghana Medical School. He's also the president of the Neurological Society of Ghana. And he's lead for the African sector or segment of the international movement for what is it now? Society for Movement Disorders, right? Prof, you're welcome.
Thank you very much, Nortey.
It's been a while. Been a while since we've had you in the studio. You see, the movement disorders one got me. It's Society for Movement Disorders.
Yes, it says Movement Disorders
Society. That's right. I knew it was MDS. So for a second, I was stuck there. But great to have you.
Thank you.
And how have you been?
Fine. Trying to recover and trying to do several things at the same time.
Yeah. That sounds like Prof. Akpalu. Most of you will know him. When we do stroke, when we do dementia, many of the other conditions to do with neurology, we bring him in. But Albert, it's Ghana month.
Yes.
I come from Teshi. So Ganyo Jimmy. Where do you come from?
I'm half Gan, half Ewe.
Oh, okay.
Yeah.
Did you know there's a fort in Teshi?
Yes.
Fort Augustaburg. Right.
Yeah.
Now in ruins.
Yes.
But we fondly call Teshi Texas. But half Gan, and then the rest of you is
from Jalukope.
Right. So are you can you introduce yourself to my listeners in Ewe? At all? Megaliswevo. Okay, Prof. I'll pardon you. We'll come back to it. But anyway, epilepsy.
Yes.
You know, a neurological disorder, a chronic disorder of the brain, right? And let's break it down for our listeners. Many people, as soon as they hear epilepsy, they think of mental illness. But let's situate it properly. What's epilepsy?
Okay, so epilepsy is a chronic neurological condition. I think it's actually the most common neurological condition. And currently, the current definition is that somebody has the propensity or is at risk of getting seizures. And what is a seizure?
Right.
So a seizure is is the manifestation of abnormal electrical discharges in your brain.
Okay.
So it depends on where the electrical discharge is, depends on how frequent it is, depends on the situation you have a seizure. Okay. So most people know seizures as the observable one, where you jerk, you fall down, you scream, you bite your tongue, and you may urinate on yourself, and then you lie down, and then that brings attention to people. That's what people are afraid of.
Okay.
But 40% of seizures are so that the type of seizure I described is called a convulsive seizure. Now, 40% of seizures, unfortunately, are non-convulsive.
Right.
And these are seizures which
meaning that we will not see the outward sign.
You will not see the outward sign. Yeah. So these are difficult to diagnose, difficult to predict. The person himself does not even know what they are aware of. So there are so many things that are associated with that. So people say they are spaced out, there's derealization, they don't know where they are at a certain point, or they are doing something and they forget what they are doing, or they have an abnormal fear or panic or anxiety which goes and comes.
Okay.
So a lot of these people may end up with the psychiatrist.
Right.
And it goes on for a long time. And some of the medicines make it worse. So there's a perpetuation.
Right.
So we need to demystify and really draw the lines for this. Yes.
All right. Folks, if you just joined us 15 minutes past the hour of 2 on Joy 99.7 FM, I'm with Professor Albert Akpalu. He's a neurologist. He's head of neurology at the Kolebu Teaching Hospital and University of Ghana Medical School. We're discussing and unmasking and demystifying epilepsy. The gas, I think the colloquial term is bligli. I hear in Akan it's
so Ghana is also
Mwen, yes.
And Akan is also Esro.
Esro.
And almost all the local languages say up, or something that you've been seized by.
You've been seized by something from above.
From above.
Okay, right. And we're understanding from him that abnormal electric charges or electrical activity within the brain. So, Prof, let me ask you. So, for many people, this is why we have a lot of, should I say, indigenous and traditional beliefs that ascribe this to supernatural or spiritual causes.
Yes.
But does the brain have electrical current running through it? Let's explain the neurology for our listeners.
So the brain, so I usually explain that the brain is made up of, let's say, about 6 to 10 billion wires, all crossing. So there's ordered chaos in your brain.
Okay.
So there's ordered chaos in your brain. So you take your brain to have a seizure. Let me digress. It's like ECG turning off your light on, off, and then you get a large surge.
Right.
And then then you get a seizure.
Right.
So that is what I'll describe a convulsive seizure as. Yes.
Right. So the brain structures, the cells use electrical impulses to communicate.
To communicate, yes.
And this has a certain rhythm or a pattern.
A pattern, yes.
So an abnormal rhythm or a surge.
Abnormal surge. So that's
Right.
what
Abnormal
abnormal
surge.
surge
Right.
in electrical activity will manifest as a seizure. Now, so
Seizure.
it depends on how high the surge is. You may have a manifestation of a jerk or shaking or falling or becoming unconscious.
Okay.
Or the surge may not be that enough, so it may give you an abnormal stare, or it may give you a derealization, or you may feel spaced out, or you think that there's something going on, but you can't really put
Okay.
what is going on.
All right. What would cause the brain to behave in this manner?
So there are several causes, but
Right.
the underlying cause is a break in the electrical connectivity.
Okay.
So we can start from birth.
Okay.
So for even before birth, from conception.
Mm-hmm.
So from conception, if they are, so we call them perinatal factors.
Right.
So if your mother drank alcohol as when she was pregnant,
Okay.
you come out with a fetal alcohol syndrome,
Right.
and you may have seizures.
Okay.
Or you had an infection, any of the infections,
Right.
or you were born prematurely,
Right.
you can develop seizures.
Okay.
Or during pregnancy, there was a delay in your birth, so there was prolonged labor,
Right.
and you came out. We use the term asphyxiated.
Asphyxia.
So the baby did not cry. So you see them slapping
Right.
the baby to get them to cry. If they don't cry early enough, then not enough oxygen goes to your brain,
Okay.
and then damage has been done.
Okay.
Jaundice after birth, we call it connectorous.
Right.
So you can develop seizures later on.
Mhm.
Then falling, we drop children
Right.
fall
Head
down,
injury.
and in injury, so falling down. Then infections, so
Okay.
cerebral malaria, meningitis, all sorts of infections which affect the brain can cause. So this is just the childhood period.
Okay.
Then there's a big argument whether knocks can give you seizures, but
Right.
I assure you some knocks can damage the
I need to
the
go and
brain.
ask Francis Ngannou. He got a big knock from Anthony Joshua. Right. So at least trauma to the head.
So trauma to the head. So
Right.
that is in infancy. Then as we grow older, falling down from heights, accidents on a motorbike without a helmet, falling down, you get a head injury. And then as the continuum continues, when you get into the elderly age, you're getting a lot of seizures post-stroke. So after a stroke, there's a lot of noise about stroke this
Right.
week.
Yeah.
So after a stroke, you can get a seizure. After a head injury, you can get a seizure. So there are several things along that continuum.
Okay.
So from childhood, no, from pre-birth to birth, post-birth to adulthood,
Okay.
and elderly, you can get seizures along
Right.
the line.
Okay. Now I understand there's many forms and many types of
Types,
seizure.
yes.
The should I say the linking presentation is the seizure itself,
seizure
which you
itself,
have
yes.
described for
Yes.
us. Okay. So if I have a seizure, let's say on account of maternal alcohol or substance use, right? Does that make me epileptic? Essentially, what I'm trying to ask is what
So
constitutes
bef-
the
bef- bef-
diagnosis?
the
Yeah.
diagnosis. So before
Yeah.
we go on, we don't use the
Right.
term epileptic anymore.
Okay.
So I'll fine you for using the. So we use the word a person living with epilepsy.
Right.
So because the term epileptic has enduring social stigma.
Okay.
There's stigma for several things, but
Mm-hmm.
the stigma for epilepsy is worse than any stigma you can imagine or
Right.
you can think about. So one of our jobs for everyone listening to us now is to try and reduce that stigma or eliminate that stigma
Okay.
by using the appropriate term.
Person living with
person
epilepsy.
living with epilepsy.
Okay.
We are copying all the other people, but person living with epilepsy
Right.
is not a derogatory term.
Okay.
Yes.
All right. So, how do you characterize or diagnose somebody?
With epilepsy. So once you have, it's a mean diagnosis, but once you have two unprovoked seizures separated by two, so separated by 24 hours, two seizures. You can have a seizure in 2022, another one in 2023.
Right.
You are living with epilepsy.
Epilepsy.
Yes.
Right. And therefore, you have the propensity to have recurrent
seizures. Yes. And then the other conditions where somebody has had a brain injury, or there's a scar in the brain, or there's a growth in the brain, or a tumor or something. So that's we don't wait for you to have the two on pro-growth. You have the risk, and you're at risk, or you're at risk of getting increased seizures.
Okay.
So we look at those things too as well.
So two or more. Right.
Two
is
or
sufficient for a diagnosis
of epilepsy.
Epilepsy.
Yes.
Okay. So now that we've understood that, can I also ask you, for the benefit of my listeners, we hear of febrile convulsions.
Convulsions, yes. So,
are those seizures?
Seizures. So we have things that we call situational seizures.
Okay.
So for example, if we go out on a Friday night and you have more alcohol to drink than I do,
okay,
and then you did not eat, you drank it on an empty stomach, and you can have a seizure.
Right.
That is a situational seizure.
Okay.
Or I'm diabetic and my blood sugar goes low or goes above the range, I can have a seizure. That is a situational seizure.
Okay.
So now when children have fevers,
right,
and the temperature is more than 39 degrees and they have a seizure,
right,
that is called a febrile convulsion.
Right.
Now, febrile convulsions predispose children to epilepsy later on.
Okay.
So there's a big debate about how many and what, but febrile convulsions can predispose you to epilepsy. So we take that in your history too as well.
It's relevant history.
Relevant history.
Right.
So there are lots of situational seizures. People take drug overdoses, people abusing cocaine or any of the hard drugs, you can have a seizure.
Okay.
So that is a situational seizure.
Right.
And that is different from an unprovoked. So we use the term an unprovoked seizure.
Right.
So it should not be provoked.
All right. Okay. Folks, if you just joined us, 24 minutes past the hour of 2 on Joy 99.7 FM. We're
99.7 FM.
trying to dissect and unmask epilepsy with the help of Professor Albert Akpalu. If you have any questions, concerns, experiences, or you want to share some localized or traditional indigenous experiences or beliefs about epilepsy, you can use our WhatsApp 055 1111 997. We're live on Facebook and YouTube, and shortly I will activate the phone line so you can get into the discussion. As Prof has already said, we're dealing with a chronic brain disorder. Chronic means it's long term. We'll get to learn and even answer the question, is there a cure? Can epilepsy be cured? It's a very important question to consider, right? And then we will also look at the different types and also get to understand the management and many other issues. If you have any questions, remember, WhatsApp is 055 1111 997, and shortly I'll activate the phone lines. Okay, so we get a sense of how we can pin it down. We get a sense of the fact that it must be unprovoked, which means that this abnormal electrical activity occurred by itself.
By itself, yes.
Right. That qualifies for the diagnosis of
epilepsy.
Epilepsy. All right. Okay. So having understood that, let me ask you also to share with my listeners, how common is this? It's the most common neurological condition.
Yes.
In Ghana, how common, and globally, how common a problem is epilepsy?
Yes. So in Ghana, it's a scary statistic, but
right,
it's extremely common. So we did a prevalence survey in Kintampo, which is the center of Ghana. So we had at least, it's 1 in 10,000 people who have epilepsy or diagnosed with epilepsy. Now there's a larger amount of people who a larger number of people who are undiagnosed.
Right.
Now, to even make it, of those who are diagnosed, less than 70% of those who are diagnosed are on treatment,
right,
or have access to treatment, or have access to trained persons with trained healthcare persons who know how to manage epilepsy.
Okay.
And to even make it more scary, the availability of anti-epileptic drugs it's beyond the reach of many of these people to as well. So we have something called a treatment gap.
Okay.
Yes.
Right. Okay. I pulled up something here. It's a 2023 research, which also suggests about 270,000 people living with epilepsy in Ghana. That probably those who have been identified.
Yes.
Right.
So that's 1% of the population. At
Right.
that time, Ghana's population was 27 million.
Okay.
So 1% of the population are living with epilepsy, and
Okay.
it may be more.
Okay. Right. So let me ask you, I mean, we've described what it is. We haven't gone into types yet. But what is the consequence? Because many people are living with this. They don't know.
No.
Right? In the indigenous context and in our local languages, we have names for it.
Yes.
So we are aware of it. But what is the consequence of untreated, undiagnosed epilepsy? If my brain does this once in a while, okay,
yes.
Everybody's seen it. Maybe it may be the convulsive type. It may be the non-convulsive type where I'm blank. I stare. I lose my train of thought. What's the consequence? Is there any damage going on?
Yes. So till recently, we did not agree on this, but now we all know that seizures damages the brain.
Okay.
If you have a seizure, you have a certain number of brain cells. As I said at the beginning, you have 6 billion brain cells.
Right.
Each time you have a seizure, you are frying up or you are destroying. Let's say let me get minimum of 10.
Right.
So you get 10 seizures a day. By the end of the day, you've lost this number of brain cells, and
Right.
as it continues, you start getting decline in your cognitive function,
Right.
in your memory, your thought processes. So
Right.
your brain gets depleted and gets degraded
Right.
with any time you have an undiagnosed and untreated seizure.
Okay. Right. So, folks, you're hearing this. If you've witnessed this in a family member, somebody you know,
Yes.
whether you know if they have access
Access, yes.
to treatment or whether they are under management or not, there's definitely something.
Yes. But not when you
Yeah.
go into our local, when you go into our region, we've been throughout the country looking at the perspectives of the different regions, the different types. So it's all over.
Right.
Once somebody with epilepsy gets a burn or gets burns,
Right.
it means that they cannot be treated again, and that is a very false premise.
That's a belief.
That is a belief across all the regions. That
Right.
once you've been burnt, you there's no chance of you to be treated. When the seizure is ongoing, do not
touch the person. So those are the myths.
Because those are the myths that
Right.
you get a seizure. The worst myth is if you inhale the flatus of somebody with a seizure, you are going to get a seizure. So all these are myths that we need.
Myths
we
about
need
the saliva.
that's saliva
and all
touching
that.
somebody. So that's why people get bent all over from Jamestown to Pram Ningo, all up north. We've seen patients or our clients who fall into fire. The worst one, somebody making banku.
Yeah.
Her breasts were in the banku, and everybody was watching her. Nobody
Nobody would
to.
touch
Nobody
or
would
help
touch
or
her.
assist this
Or
person
assist
because
them.
the local belief
Yes.
is that if you touch this person, you will get the
You
epilepsy.
get the epilepsy.
All right, let me hit you straight with this. So, is it contagious? Let's hit that one off straight. Can you get or catch epilepsy from somebody?
If I'm allowed to use the word age, hell no, you cannot
Right.
get.
You cannot.
You cannot.
It
It
is
is
not
not contagious.
Contagious.
It is not contagious.
Okay.
So we need to show love of our persons living with epilepsy. Many years ago, when we started this epilepsy journey,
Right.
we had a workshop for parents of children living with epilepsy at the teachers' hall. And as we're giving our lecture, one of the children had a seizure. This is parents of children with epilepsy,
Right.
and there was like they had dropped a bomb in the middle
Scattered.
of everybody scattered. So we
Whoa.
called them back and told them, look, that's what we are here for. This is your own children, and this is they also have the same thing. So let us show some empathy. And luckily, by the end of the lecture, another person had a seizure. And this time, everybody came round. So education.
Okay.
So I think that's what we are missing.
Right.
Education.
Right. 31 minutes past the hour of 2 on Joy 99.7 FM. We're having an interesting discussion, unmasking and demystifying epilepsy. If you have any questions, concerns, WhatsApp is 055 11 11 997. We're live on Facebook and YouTube, and shortly I will activate the phone line. Oye Nafenya, I see your greetings. You're most welcome aboard as usual. You're a regular. This one says, good afternoon, Nortey. The Akan name is Ocha, and I've heard Echa too, right?
Okay,
Ocha.
Ocha. Henrietta
Mante from Audome Estate shares that. Thank you. Oyuradong. This one is a photo. Okay, it's something else. I remember, or I recall, I've seen several people with burns, and you sent me one of was it an SHS student?
Yes. Who came home, that she finished her exams,
right?
Came home and was frying fish, and this is her household.
Mm-hmm.
And she had a seizure, and both hands got burned. So she had to have extensive plastic surgery to.
Yeah. She's lost her fingers.
She's lost her fingers, but
in fact, it even looks like if it wasn't for the burns, you think it was Hansen's disease.
Hansen's disease, yes.
So she just got these clubs.
Yes.
For her hands, and it was secondary to epilepsy.
Secondary to epilepsy, because the people in her household did not take her off the fire. So we need to reduce the social stigma.
Okay, right. This is from Dede, Maryland. Dede, your birthday was on International Women's Day. A regular, a very loyal listener. According to Doc, due to stigma, the name was polished from epilepsy patient to someone living with epilepsy. I had used the old term epileptic.
Epileptic, yes.
Right? And he corrected and gave the context, right? The stigma and discrimination. What is the difference? The word epilepsy is still present in both descriptions, or does it appear that one sounds more palatable than the other? This is from Dede.
So it's not so the word was that we used was epileptic.
Epileptic.
So that is to describe somebody. People think there's an epileptic personality. Most people think the people with epileptic are people who are walking around the street and drooling with saliva and having their eyes and mouths open.
Right.
No, so that is a different subset of some children with cerebral palsy have seizures, right? And everybody has the mindset.
Even those with Down syndrome.
Yeah, even those with Down. So some people have the mindset that is what somebody living with epilepsy should look like. Yes.
Right. Okay. Please wish him. Oh, he's my best boss ever. Happy birthday, Oga Chamba Nurokinan, unit head of Access Bank Contact Center, an exemplary leader, motivated and a mentor to the team. May all your heart's desires. Okay, from Seth Kojo Kwachi. Right. I thought it was a shout out to you. I'll bet you had your birthday. Was it last 2 weeks?
Last 2 weeks.
Yeah. Pisces, eh?
Pisces, yeah.
All right. So if you have any questions, concerns, we'll address them. So coming back to the business of the day, and the phone line is activated 030-221-6541. We're having a discussion and trying to unmask epilepsy, seizure disorder. Right, with Professor Albert Akpalu of the Kolebu Teaching Hospital, Department of Medicine and Therapeutics. He heads the neurology department or wing of that department. Right. So coming back, we've understood what a seizure is. We know it's a surge in electrical activity. Yes. What are the types? You've mentioned broadly that some are silent or non-convulsive and therefore very easily missed by diagnosis, right? But let's break it down. And
so for the convulsive seizures, which are the most common types, we have what we call a focal or a generalized seizure. So a focal means you can just on one side, I'm sitting here, my face is twitching to one side, or my hand is twitching. It may, both the focal and generalized, the focal may have loss of awareness or without loss of awareness.
Which means that whilst this activity is going on,
you are conscious.
I'm conscious.
You are aware of what is going on.
Right.
And sometimes you are not aware of what is going on.
Right.
Now, the generalized seizures, which are, so the commonest ones are in children in school. So we expect the teachers to pick this up. So please, if you are a teacher, you have a child in class who you say is absent-minded, you're talking to him, his eyes are flickering for 2-3 seconds, and he comes back. These are the children that get the most knocks, and or the parents say they are stubborn, they are lazy, they are just having absence. Yes.
absent
Absent,
because
because he's had an event at that time.
Right.
So we need to pick these children
then he
up.
comes back.
And he comes
to
back
consciousness.
to consciousness.
That's why we call them absent.
Absent seizures.
Is this
yes.
what we used to call petit mal?
Petit mal, but the nomenclature has changed.
It's changed now.
It's absent seizure.
Absence.
So it's a generalized seizure with loss of awareness.
Okay, Prof, if I may, let me backpedal. Focal seizures.
Yes.
You mentioned a part of the body twitching.
Yes.
Is it because the seizure is
Located at that particular part of the brain? And the brain is a very interesting organ
Right.
that we are still beginning to understand. So it's a complex organ, but we have various parts of the brain.
Okay.
So frontal lobe is for your memory. It stores your memory for your behavior. Your temporal lobe, which is at the side of the side of your head, also forms your memory. Your behavior is also triggered from that, and that's the most easily triggered zone of your brain.
Okay.
Part of your parietal lobe, which is the other side, is for your speech, and then the back of your brain, which is called the occipital lobe, is for your vision. So you can have, all of a sudden, I'm sitting here and I'm not seeing you.
Okay.
You may have an occipital lobe seizure.
Okay.
I may start getting angry, tearing down the place, and I'll have what we call the old type of a temporal lobe seizure. Or frontal lobe. I start behaving unusually.
So with the focal,
it's localized to that
specific point in the brain.
In the brain.
Okay.
Then we have the generalized, which affects all the zones of the brain
Right.
and affects the motor system. So that's what makes us jerk.
Okay.
So there are different descriptions.
Okay.
So we have our hands get tight. We call that tonic.
The tonic.
And then
The
clonic.
rigid- the
means
rigid.
The rigid. So the shaking
Right.
that you have is called tonic, clonic.
Clonic.
Then we have atonic, where you just fall, and we have a combinations
Right.
of
So it's
of
important
those, yes.
to describe
To
what
describe
happens to the person,
yes.
right?
So always take a note. Now, to maybe make it more difficult, there's people who faint or who faint from extreme exhaustion or heat, or hear some bad news, can also jerk. So it's difficult to tell the difference between the two.
Right. Okay. So it's important to critically observe what happens. All right. I will take Prof through with questions on what to do during a seizure. We're just trying to understand the types of seizure, right? So it can be focal, it can be generalized. Nortey, good afternoon to you and your guest. When I lived in the UK, I looked after a lady who was living with epilepsy, all right? One day before a seizure, I think I heard a click sound in her head. Did I hear right? This is Abna Inoyibi. Anyway, thank you so much for the education. She thinks she heard something clicking in the woman's head.
So, I was not there, but I don't think that is like. But sometimes we have something called an aura.
Right.
So an aura is something that happens before a seizure comes. And then before a seizure, some people can make a loud noise.
Right.
So that may be what he heard as a click.
Right.
So an aura is a precursor
Right.
to a seizure, but we think it's a seizure.
Right.
So some people have a bad smell, they see a black cat, they see something
Right.
happens all the time before the seizure,
Right.
and that triggers it.
Okay. Abna, I know that, and Prof can confirm this, some people also, as part of the seizure, there's this lip smacking and tongue clicking, which could be
that's what
you
you heard. Yeah.
Right. Okay. Please, is there any relationship between epilepsy and fire? This is about hazard, really.
About hazard, yes.
Right.
So the relationship is that we have to supervise, not stop people. So there's something that I call self-stigma or parental stigma.
Right.
Because they're afraid that they'll have a seizure whilst crossing the road or whilst cooking. They are kept in the corner of the house. They don't do anything at all. And that is not good for their human rights.
Okay.
So anybody with a seizure, yes, if they are cooking, let them be supervised.
Right.
If they're having uncontrolled seizures or they are getting 2 to 3 or 4 seizures per day, then you can prevent them from getting near fire.
Okay.
But otherwise, if they are well controlled, so be it. Let them live their normal lives.
Okay.
Our goal is to allow our patients living with epilepsy to live as a normal possible life as possible.
Okay.
Many of us crossing the road may be knocked down by an Okada or something can knock us down.
Right.
So it's the same risk for people living with epilepsy.
Okay. Right. Let me remind you the phone line is active 0302-216541. 0302-216541. You can ask the question yourself. Good afternoon, Nortey. Please ask for me, is epilepsy spiritual and is it also hereditary? This is Ajiman Joseph in Community 9, Tema.
Good. So I can assure you that we've had
Prof, if I may, let me just read a couple more. Then, good afternoon, Nortey and Prof. What is Blig Bli? My condolences to Mrs. Priscilla Na Akleso, a wife of the former MP of La Obama, who buried her mother yesterday. Have a blessed Sunday, Nortey, from Sarah Manfo in Winneba. So she's asking, what is Blig Bli, right? Because of the tonic-clonic seizure, sometimes they say
so that's
Blig
what
Bli,
yes.
right? That's what they refer to it as.
And also the Blig Bli name is a derogatory name.
Okay.
For what? So Blig Bli. So if you go into the gang connotation of that, it means you are just falling down, and there's nothing you can do about it. So we need to change the social constructs of that. Now
I'm tempted to say okay, but I mean Blig Bli. It's trying to describe what is happening to the person during the seizure.
During the seizure, yes.
Right, and you're saying that is also derogatory.
Yes.
So how should they capture what is happening to the person?
We'll go into the ethnographic.
All right. Okay. My God, brothers and sisters, I have a caller on the line. Let me take the call. Hello, good afternoon.
Good afternoon, Oti.
Yes, you're welcome. Who am I speaking to?
Oti Boateng.
Oti, right. Right, thank you. Share with us quickly.
Yeah. I don't. You discussed last week or only today is the week. I travel like 3 weeks time, so I was thinking that my question may be asked already, or should I ask?
Let's go ahead with your question quickly.
I want to ask, how can we stop it? Is that generational one, or it just come just like that?
Okay, can it be prevented? And it goes back to Ajiman Joseph's question, spiritual, hereditary, and so on. So that's what Oti Boateng is asking. Thank you, Oti.
Okay, thank you.
Right. So those are the questions we have. Let me just quickly read a few more. Good afternoon, Nortey. How are you? And Doc, he's now Prof. I was not around last 2 weeks, so I missed the vital information about Ultimate Health Program. But today I'm listening live and colored. Now, my question is, where does epilepsy originate from? Secondly, the causes of epilepsy are in different categories. So I want Doc to explain for me what is meant by structure, genetic, metabolic, infectious, immune, and unknown causes. Hayford in Bato. We've done a bit of the breakdown, right? I don't know. Prof is writing or noting that down, and he'll give you a response. This one says, good afternoon. No, this is to Samson on the legal program. Henrietta Mante says, what about those who sneeze frequently and have chronic cold? Are they not prone to epilepsy? Henrietta Mante wants to know that. And she wants your contact as well. So, sneezing?
No
relationship.
No relationship.
Okie dokie.
Yes.
And then hereditary, spiritual.
So there are causes of epilepsy. So structural. I've talked about, you have a scar, you have a growth in your brain, you have a tumor. There's something in your brain which shouldn't be there. We call them malformations of cortical development. As your brain is forming, there should be a part of your brain is made out of gray matter and white matter. If white is where gray should be, it's like a scar. It's like a break. That's structural.
If you have a stroke, you can have
a structural lesion, and that goes. So that's a good genetic. There are some genetic causes of epilepsy.
Okay.
So there's a difference between genetic and hereditary. You can interchange them. But somebody who has epilepsy does not mean that their child is going to have epilepsy. That does not mean it's sine qua non. Does not mean that it's going to happen that you're going to have epilepsy. No, there are different types
but it's significant history.
There's a significant history. So there are some genetic epilepsy. So there's one where the people they are holding something and it drops. We call that myoclonic epilepsy.
Right.
So that's we call it juvenile myoclonic epilepsy. There are hereditary constructs to that.
Okay.
The metabolic. I've talked about when you have hypoglycemia, low blood sugar, alcohol levels, in chronic kidney disease.
Okay.
You can have seizures as a result of that.
Okay.
Infections, I talked about
Yeah.
malaria and all of that. The immune causes, COVID causes seizures.
Right.
Now, the unknown is where the trouble comes in. So the unknown factors, we are now finding some more genetic causes for the unknown causes. So
Right.
because a lot of them, about 30% of seizures are unknown,
Okay.
that's where the spiritual connotation comes in.
Right.
What should cause a condition which would cause somebody to get up, seize, fall down, become unconscious,
Right.
foam at the mouth, and come back to normal?
Okay.
It has to be spiritual, but
Okay.
that is not what the cause is.
All right. And when it's unknown, is that what we used to call idiopathic?
Idiopathic, yes.
Right. Okay. When it's unknown, then that gives rise to speculation.
Speculation that something is happening, that it is a curse. So if you go around the country, most people think having epilepsy, there was a curse. You had sex in the bush. That's
Okay.
how come you were
So it's a
born.
punishment.
And then it is a punishment
Right.
for what you are doing. You owe somebody money, and then you are cursed.
Okay.
And it goes on. But the underpinning thing is that whatever we tell our patients, what you think the cause is, we need to treat.
Okay.
Because we need to stop damage to your brain.
Okay, 48 minutes past the hour of 2 on Joy 99.7 FM. We're discussing epilepsy, seizure disorder, right? And we are in the company of Professor Albert Akpalu of the Kolebu Teaching Hospital and the University of Ghana Medical School. We're breaking it down and shoving aside the myths and misinformation as well. Abdul Rashid, the question you've asked about seizures and brain tumor has been asked and
Excellent.
answered by Prof. All right. A tumor is an abnormality in the brain, and it can also
it's an
cause
abnormal growth.
Yeah, it can also cause a seizure. Prof, let me just quickly ask again so that we get some clarity on this. So we can diagnose. We've got the criteria:
Yes.
2 or more seizures,
Seizures,
and so
yes.
on. But is there any conclusive investigation or criteria?
Yes.
We hear of imaging and
Yes,
other things
yeah.
that can
So
confirm.
but before we get to imaging,
Okay.
the best way to make a diagnosis of epilepsy is to take a seizure history.
Okay.
And that history has pertinent questions. Remember,
Right.
I started from before birth
Right.
coming out. So there are pertinent questions that we need to ask. So
Okay.
we found out that it's difficult for our health professionals to memorize all these questions or to go through the plan. So
Right.
currently we are trying to develop an app which will help our health personnel to be able to diagnose both convulsive and non-convulsive seizures adequately. So
All right.
it's a project that is ongoing
Okay.
in Shai Osudoku and
Right.
Ningo Pram Pram. It's called Pina Study. So those of our clients there have been seeing us over the last 2 years. So we are getting close to that. But after the history, so making a diagnosis is history.
Right.
The next thing we can do is called an EEG.
Right.
EEG is an electroencephalogram,
Right.
which just measures the active brain activity on your brain.
Okay.
Unfortunately, Ghana being what it is, there's a lot of people doing EEGs who are not supposed to be doing EEGs. So please, if you are getting an EEG, it's not signed by a neurologist or it's not certified, do not accept that result. Because to get a false report, it means that you're going to treat somebody who does not have epilepsy, and
Right.
we have many of those people. So
Okay.
please be discerning at your station and know where you're going to do your EEG at.
So the EEG
Yes.
will plot brain activity.
What brain activity, and tell us at the time at which it is done that you have a focal or generalized, or this is the
Okay.
type of seizures that you have.
Okay.
But it is an aid.
Right.
Because you do it, as I said, it's a surge of electrical activity in your brain. So if you do it when the brain is quiet, it will be
Right.
normal.
Okay.
So you need to do it closer to the time, and it is an aid.
Right.
You also use it to monitor progress of a
Right.
patient.
Okay.
That you are taking medicine for a year. How are we doing? You are still having brain activity. Means we need to continue.
Okay.
So the EEG is a guide.
Right.
We need to do a brain scan, a head scan, or an MRI scan to look at the various things that I talked about earlier, whether they're abnormal patterns or abnormal collections in the brain or abnormal wiring of the brain. That helps us to tell that, yes, there's a problem here, so let's go and look at it. I'll bring it here again because there's an area in the middle of the brain called the hippocampus. Hippocampus in Greek means a horn.
Yeah.
So there's a horn there. That is the most seizurogenic part of your brain.
Right.
So in certain people, it is either small or scarred.
Okay.
So if it is scarred, it's one of the low-hanging fruits you can do.
So you can
and
pick
go and
that up
pick that
on a
up
scan.
on a scan. So if it is there and we do the right things, we can do epilepsy surgery to remove that to reduce your risk of seizures.
Okay.
So that's one of the main reasons why we do the imaging.
Okay.
And of course, look for all the other things that can cause a seizure.
Okie dokie. 52 minutes already past the hour of 2. But what I'm going to ask you, Prof, is that so what happens during the seizure, especially the convulsive type,
Yes.
and what should we do and what should we not do?
So during the seizure,
Let me ask,
Yes.
is the person in any danger?
then yes. So the person is in danger. If I'm here, I have a seizure, remove me away from sharp objects or from blocks. Just leave me on the floor. The seizure will last for 2 to 3 minutes.
Okay, let me focus
Yes.
that again. So if or in the absence of any of these external hazards,
Yes.
I'm experiencing a seizure.
Yes.
Am I in danger? Because that's the reason why people feel the urge or the need to intervene.
So the main people are afraid that they will swallow their tongue. So their first is to try and put something into their mouth. Do not put. Hear it from me today. Do not put anything into the person's mouth.
Do not force the mouth
No
open.
Don't force the mouth. Don't put your hand there. No spoons.
The person
no
cannot
spatula. Cannot
and will
swallow
not
your tongue.
Swallow his or her
the
tongue.
You rather injure the patient by aspirate, so
Right.
pushing the teeth. Sometimes we see people with mobile phones ringing because if somebody has stuck a Nokia, what do you call that Nokia phone, the
310.
Nokia 310 into their mouth. So no, leave the person on the side, turn him on the left side, let the seizure finish. If he has dentures or something, then you have to swipe the mouth, and after the seizure has ended,
Okay.
sorry, but do not put anything in the patient's mouth.
Do not put
Do
anything.
not pour palm oil. Do not pour water. Let the patient be. The seizure will come to an end.
These things can choke the person.
Can choke the patient. You head the if you are by the patient and it's hitting the head, you can just put your leg there put a pillow or remove or get a coat and let them lie down. They'll come round.
Because the clonic phase will lapse.
Will lapse, yes.
Right?
So they'll come round. So when they come round, they may be confused, they may be aggressive, they may be incontinent. So make them comfortable. They'll come round and you stand them.
Incontinent meaning they lose
They
control of
lose
the
control of the bowel and their
bladder.
bladder.
Right, okay.
Now, when the seizure goes beyond, the operational definition is 5 minutes.
Right.
But we usually don't wait for 5 minutes. When it goes beyond 5 minutes, then we call that status epilepticus. So status means that the seizure is continuing
recurrent.
and recurrent. So that needs to be dealt with. So we need to take the patient to the nearest health facility where the seizure will be aborted. So, but even in the health facility, when the patient is having a clonic phase, you cannot set a line. You cannot put. So if for the babies it's easy, we give rectal diazepam.
Okay.
But in the adults, for goodness sake, remove the needle before you put it into the rectum.
Right.
So we can abort that, but most seizures are self-limiting.
Okay.
2 to 3 minutes, they come round
It will
and
subside.
then it will subside.
Okay.
So do not rush, do not hold, carry, push, pin the patient down. People dislocate their shoulders because people are pinning them down. They are struggling with them. And they fracture, they dislocate their shoulders. They have fractures. They have broken teeth because they are pushing spoons and things through their mouth.
Okay.
So do not. And they'll come round, and then you make them comfortable and ask them whether they've taken their medication, whether they know most causes of most triggers are that they don't take their medication.
Right.
They're under stress. They have not eaten. So my 5 rules to my patients, or the how to reduce your seizures are avoid anger, avoid hunger. Okay, I could say it's my gun blood has gone away. So hunger, don't drink hunger, anger.
I get you now.
Lack of
Right.
sleep, stress, and increased screen time.
Okay.
These are common factors in our youth. A lot of people are spending hours on social media,
Gadgets,
clicking
tablets.
gadgets, tablets. That is bad news for our patients living with epilepsy.
Okay.
So anger, hunger, lack of sleep,
Right.
stress, and increased screen time.
Okay, these could be termed triggers.
Triggers, yes.
Right.
So in our secondary schools, because some schools they go for breakfast after 2 periods, we get a lot of our clients having seizures during that time or during assembly. So please let them eat, let them keep their food, and they should not be hungry.
Okay.
Hunger is a big trigger for
right.
seizures.
This, we've almost run out of time, but so if you are known to have this condition,
Yes.
whether diagnosed or being medically managed, it should be communicated.
Yes.
Your school should know,
So
your
sc-
employer
yes.
should know,
So
your
the-
spouse
so-
should
So
know.
that is where the stigma
comes in.
That's where the stigma comes
Right.
in. That's where we can do a whole show on disclosure. So I had 2 people who wanted to get married. One knew she was taking medicine. The other one did not disclose. So she opened the glove compartment and saw carbamazepine. So she said, "Okay, there's 1-1 draw. You don't tell me too. I not tell you. So we are there. But disclosure is key.
Okay.
So we need to do a lot of counseling
Right.
because of our social myths. People, before you get married, one of the things they go and find out whether you have
Is there
epilepsy.
Epilepsy in the family.
So no marriage at all. If you are being beaten, that is fine.
Okay.
Epilepsy, no. And all these human rights things are coming up. So we must try and reduce the stigma. People who living with epilepsy are normal people. They are very intelligent. They only have that problem during that surge of electrical activity.
Okay.
After that,
They
they
are
are
okay.
they are okay. They are
Right.
fine.
So does this affect them in any other way, reproductive wise or anything?
No, so persons living with epilepsy can have normal fecundity.
Right.
So fecundity means the ability to
To
produce.
reproduce.
But there's a caveat. If you're on medication, you're a female or a male, you must take folic acid if you're in the reproductive age group, because some of the medications can affect the baby. We have some bad medicines which affect the baby.
All right.
So no, not on those ones. So all health practitioners or anybody, make sure you are on folic acid, you are eating green leafy vegetables to improve your chances of having a normal fetus.
Right. In other countries, Prof, there are categories of driver's license and other things.
Yes.
Your comments on epilepsy
So
and driving.
epilepsy and driving, once you are well controlled for 6 months, no active convulsive epilepsy, you are allowed to drive. Of course, there are categories of licenses you are not allowed to drive. You can't drive a tipper truck or a long distance bus or fly on airplane.
Right. Can you be a passenger on a plane?
You can be a passenger on the
can
airplane.
fly.
You can fly, but not a pilot. You can swim once there's supervision.
Right.
Yes.
Once there's supervision, you
yes.
can swim.
You can swim, yes.
Right. There's another question come up. We've answered it, but just quickly hit on that. Saliva
Yes.
and transmission.
Transmission. So saliva, it is because they are drooling. They've lost their sense of awareness. So the saliva is coming down. It is not contagious. It's because of this saliva. Along the coast, they say don't eat okra, don't eat snails. These are nutritious foods for our patients living with epilepsy. So just clean them up. Nothing will happen to you. The worst one is standing in the shadow of somebody with epilepsy, that you get epilepsy. So
All
please,
these-
let us show compassion. It is their human rights. We need to make as much noise we are doing in epilepsy for some of the other things that they are talking about this week. I'll not go there, but we need everybody to advocate for our persons living with epilepsy.
Okay.
They need as much rights as all of us.
Right. And then, this business of, well, of course, a lot of it also occurs in infancy and childhood.
Yes.
Schools, parents, what
yes.
are we doing
so
there?
I'm seeing a lot of 10, 12-year-olds coming to me or being sent to me by the psychologists with poor academic performance.
Right.
When we go back into the history, they had bad birth history and
Asphyxia,
asphyxia,
all sorts of-
and they've been having seizures.
Right.
So they've destroyed 10, 12 years, and you've destroyed a lot of your brain cells. So please, let us pick these up early.
Yep.
Your child is not doing well. Send him for an assessment. Stop knocking. Stop kicking. Stop hitting them. Stop telling them they are lazy. They are absent-minded. We are on the situation. you not go find anything. No, let
Right.
us assess
Let's
our
assess.
children. Assess first before we blame.
Okay, all right. Assess first before we blame, stigmatize, and discriminate, right? Epilepsy is a big one. We've done it several times over the years with Professor Albert Akpalu. He's been, should I say, generous enough to spend time with us. He flies, he zips all over the world. He's on many of the world, global top, should I say, agencies and organizations in his field. So when I get him like this, you need to know. I couldn't get him 2 weeks ago because he was chilling with his wife on his birthday. But it's great to have you, Albert, and this has been truly, truly revealing and informing as well. I hope we've empowered you and also informed and transformed you. But he will give us, you see, the level at which he perches. Even when he's absent, he can delegate. So we'll have a second take on this, where we'll look at more of the do's and don'ts, and then also treatment and management.
Yes.
And whether we can really talk of remission or cure when it comes to epilepsy. Many thanks, Prof. Albert
Thank
Akpalu,
you.
for spending time with us.
Yeah. So you have Dr. Fifi Dodu. So it's good news. Since we have 16 neurologists now.
Oh.
So we are doing one neurologist per region.
Okay.
So we are
Fifi I know very well.
50 years. We are achieving our own manifesto goals. So we will do that. So he'll be with us here
Next week,
and then
we'll go into
we'll
treatment, management, and then your do's and don'ts when you are on treatment, okay? And then how we, should I say, close or bridge the treatment gap.
Yes.
Too many people are suffering unnecessarily, and there are new lines of treatment as well.
Yes.
Many people are on old, perhaps outmoded treatments as well.
yes.
There are more effective treatments available. Many thanks again, Prof.
Many thanks, Nortey.
Akpalu.
Okay, right.